I think you're muted, by the way.
Thank you. Welcome to week 5. We have a couple of minutes before we get started. Does anybody have any questions about this week's assignments? You have your math calculations to get submitted by this coming Sunday. Some of you have already submitted them, and that's good. You have a quiz today, quiz 3, which covers most of last week, 2 from this week. And then your teaching plan. And like I promised, I will send you a sample or example of one that I did. And you could just follow that same format. So just plug in your information. You might pick something else. I picked a type 2 diabetic that had a baby with respiratory distress, which is not uncommon for a diabetic mother to have a baby with respiratory problems. So that's what I chose. And the newborn assessment is very brief, okay? And I will tell you where in your book you can find that information and tell you just kind of which ones to choose from. So I'm doing a lot for you, but I think it will help you when we get to newborn in a couple of weeks. Okay. If you've not signed up to meet with me so we can go over exam 1 together to see maybe what concepts you don't understand, or maybe it was something else about the exam. Maybe you went through it too quickly, or maybe it was your math. So that's why it's really good to go over it with me. Even if you got a 98 or 99%, it would still be good to know which one that you didn't get correct. I can't go over the specific questions. You will probably figure out which ones they are if you remember, but at least let's talk about the particular essence of the questions. So this is week 5. For next week, we will be having postings of review sessions again for exam 2. That's in week 7. So plan on attending as many as you can. And I'll do the same thing I did last time, post the schedule and then add the recordings to it. I do think that this next exam is going to be easier for you. The first exam, I admit, it was a difficult exam for the very first time in OB. It required a lot of deep thinking that maybe you haven't learned how to do yet. So hopefully you will pick up and learn how to do that. So you'll do better on the second exam if you weren't satisfied with your first exam score. Okay. What you see on the screen in front of you, do you see the okay. So I want you to read this and tell me in the chat what the answer is. Give you another minute or so to think about it. If you reading it again, you can change your mind. Okay. So you have a 36-week gestation client who is in a motor vehicle accident. And when you come to meet them in the ER, you see she's lying on a backboard. And they were reporting her blood pressure being 80/50. She's not hurting. She's awake. Heart rate 130. What do you think? What cues are in that statement? What do you see in that statement that draws your attention?
She's laying supine.
She's lying supine. Okay, that's one cue. What else do you see?
Hypotension.
Okay, hypotension. Anything else?
She's tachycardic at 130.
So she's really tachycardic, isn't she, at 130? And she's 36 weeks. Sorry, let me change that. 36 weeks. Okay, so what is your hypothesis? What do you think's going on?
Supine hypotension.
Supine hypotension. Yeah. So that's correct. And then your intervention is what?
Tilt the backboard sideways.
Yes. She's lying on that vena cava, which has dropped her blood pressure. Okay. Could she be bleeding internally? Yeah. But we can do one thing right away, can't we? We can turn her over on her side, her left side, to give as much possible blood flow to that placenta, get her off that vena cava. And then if we need to, if her blood pressure remains low, what would we intervene then? What would we do then? You've got her tilted up, but her blood pressure is still low. What would you do?
I would say bolus.
Okay, do an IV bolus. Definitely get some IVs in there. Probably need to do an ultrasound. Make sure nothing is going wrong with the baby. Good. Oxygen probably too, huh? Some oxygen. Okay, good. You could palpate the abdomen to see if she is having any contractions, and you could also collect blood for a CBC. Those are other things that you could do, but the priority is getting blood flow to the placenta. Good. So what are we talking about today? We're doing high risk. Let's see. High risk. So we're talking about pre-existing diseases before pregnancy. In other words, a diabetic who gets pregnant. And then we need to discuss something about the things that can occur during the pregnancy, usually after that 20th week. Gestational issues, issues that come up that diagnose the mother with high risk. Something is causing some behaviors or concerns about fetal or mother well-being. Okay, so other than diabetes, what are some pre-existing conditions that you think might cause problems during a pregnancy?
Hypertension.
Okay, Corey, hypertension. What kinds of things might you see? What are some possible outcomes if mother has high blood pressure before she's pregnant?
Some preeclampsia.
Okay, because maybe she doesn't have a healthy placenta. Okay. What else? It was on your exam. It was about intrauterine growth restriction. When mother has high blood pressure, the blood flow into the placenta is not as dilated. We need low pressure within the placenta itself, that interface. So reduced size of baby. Okay. So intrauterine growth restriction because of high blood pressure. Okay. What else maybe? Maybe preterm delivery, early delivery, that sort of thing. Okay. So what are some other things that you might cause problems in pregnancy besides hypertension, chronic hypertension, diabetes?
Obesity.
Obesity. Oh my goodness. Obesity goes in all sorts of directions. So when you think of an obese client getting pregnant, what is she at risk for? A lot of things, just about everything. So, like what? Obesity. Well,
Diabetes, hypertension.
yeah, gestational diabetes, gestational hypertension, stillbirth, infections, labor difficulty. So there's a lot that goes along with obesity. And obesity, diabetes, hypertension, they all kind of overlap, don't they? One cause the other cause one, and or they just occur at the same time. Okay, so we'll talk about that a little bit today. I do want to start with the term hyperglycemia. So who can define hyperglycemia for me? What do we mean by hyperglycemia?
It's when your sugar's high.
Okay, so blood sugar above what it should be at that time of the day for you, okay? Hyperglycemia in pregnancy affects early pregnancy all the way through and the end, okay? Hyperglycemia is not tolerated well in pregnancy. A level of 200 milligrams per deciliter is considered very dangerous for a diabetic. She needs to go to the emergency room. Okay, she could easily go into acidosis, ketoacidosis. In other words, her sugar is so high that she burns ketones instead because she doesn't have enough insulin. Okay, hyperglycemia is not having adequate insulin to open the cells. Okay, and most of the hyperglycemia is about insulin resistance. Okay, early in pregnancy, the need for insulin is lower, and this is for all clients. Okay, so a diabetic client, we might have to drop her medications a little bit, the dose, drop them down a little bit. Okay, but as beginning 20 weeks, that need is increasing. The insulin resistance increases, so we need to give more. And this is because the baby needs the sugar. Okay. So if mother is hyperglycemic, so is the fetus. That's a really important concept to know. Okay, if mother is hyperglycemic, so is the baby. If mother's hypo, so is the baby. Remember, their blood is interfacing. Okay, sugar easily passes, glucose easily passes to the fetus. Insulin doesn't. The fetus at 12 weeks makes its own insulin. Okay, so hyperglycemia is high blood glucose that causes some side effects. So symptoms of hyperglycemia. This is a med-surg question. What's a symptom of hyperglycemia? Do this. Why don't we break up? Let's see, there's only 11 of you here. Azzy, you need to turn your, and Annie, you need to turn your videos on. Yeah, and I need to see your face.
It keeps
Same with you,
messing up
Rocky.
and I don't want to cause a distraction. That's why I keep clicking it on and off.
What's wrong?
I'm not sure. Just keep doing that and I don't want to cause a distraction. That's why I keep clicking it off.
Okay, so let's break up into groups and work on this PowerPoint or this concept map that I have here. So what I want you to do, let's see, there's 12 of you. I'm breaking you up into 3 groups. Group 1, I want you to work on the clients that are at risk, the stuff on top. Symptoms, the clients who are at risk, and preconception concerns. Okay. Group 2, I want you to work on the antepartum concerns. And then group 3, work on the postpartum. And I'll do the intrapartum. Okay. So let me make some rooms out. 3 rooms, and it's just going to automatically put you in a room. So group 1, define what are some symptoms of hyperglycemia, what clients are at risk, and what are some preconception concerns. What does that have to do with it? Okay, group 2, antepartum, in other words, prenatal, during those first before she goes into labor, what are some concerns that you see, maternal and fetal? And then postpartum, group 3. Okay. So, yeah, there we go. Priscilla. I know I didn't give you a whole lot of time. Just waiting for everybody else to join. Okay, now we're coming back together. Just a little hint of what we're going to be discussing in detail today, okay? So what we need to do before we discuss all that, we need to do your quiz. Okay, so hopefully that a little bit might have helped you a little bit. Okay, so go ahead and go to your modules, stay on camera, and your quiz should be available for you now to go ahead and take it. Don't go too quickly. Okay. All right, quiz 3 finished. Okay. So let's talk about hyperglycemia in pregnancy. Let me do a little bit of a slide presentation, and then we'll go back to what you were working on and work through it, okay? So let's see. So risk factors for diabetes in general, in the general population, okay? Family history, okay? Obesity. What's the third one? Can you see my slide? Okay. What do you think the third one is?
Sedentary.
Sedentary lifestyle. In other words, not active enough. Okay. What about number 4? Another risk factor for developing diabetes.
Age.
Age. Yeah, age. And number 5, does anybody know what number 5 is?
Gestational diabetes.
Gestational diabetes. A woman that develops diabetes only during her pregnancy. Okay. And then what's the last one?
Your race.
Race. So what population is more prone to develop diabetes? What group of people? What race?
Hispanics.
Hispanic, Latino, Latinas. Yes, yes, exactly. So since we know this, then we can kind of plan preconceptually, talk about family history, talk about maybe they're obese, okay? Maybe they are already a diabetic. What do we do? Maybe they are older, okay? So a lot of this does come into play when we're talking with a pregnant woman. Okay, let's see. Let me make this bigger. All right. In this slide set, and I just posted it in the announcements because there's a lot of pathophys in it. Understanding what diabetes is. What are some symptoms and signs of diabetes? Well, believe it or not, the number 1 sign is thirst. Symptom is thirst. Okay, and then weight loss. Even though they're obese, if they develop diabetes, they don't have the glucose entering their cells, and so their cells begin to starve. So there's a lot that plays into the pathophysiology, what is actually occurring at the micro level, okay? So glycosuria, polydipsia, polyphagia, and polyuria. Those are the symptoms of the onset of diabetes. Diabetes is diagnosed when an A1C reaches 6.5. Okay, you're a diabetic if your A1C is 6.5. Okay. So glycosuria, what is it? Can you guess what it is? Just by looking at the word urea.
Is that sugar in your urine?
Sugar in the urine, yes, exactly. What's polydipsia?
Isn't it excessive thirst?
Thirst, yeah, wanting to drink all the time, wanting to dip the ladle in the water and drink all the time. Polydipsia, polyphagia,
Eating.
eating a lot, and yet still losing weight. Okay, and then polyuria would be
Is it like
glycose. Go ahead, Priscilla.
frequent urination?
Okay. So if there's a lot of sugar in the urine, there's water being pulled with it. So there's polyuria. Okay. So these are the signs of hyperglycemia. Okay. So some of the long-term effects of hyperglycemia, and this is more with type 1 or type 2 diabetics, is damage to blood vessels, small and large. We see premature atherosclerosis, retina, the retina of the eyes, the vessels around the retina are damaged. People with diabetes begin to lose their sight. They have to have laser therapy on the vessels. Nephropathy is the kidneys. The kidneys are affected. Somebody is a severe type 2 diabetic and isn't very well controlled, their kidneys are being damaged, they're going to end up on dialysis. And then neuropathy, the damage of nerves. Diabetics are susceptible to infections at any stage of their life. So what is the implications then if we have a woman with type 2 diabetes that comes to the office? What does it mean for you as a nurse?
You mean like what do we do for her, basically?
Yeah, what are some things? Yeah, big picture, Annie. What are some, as a nurse, you can't fix her, but what can you do?
Give her a non-stress test, maybe about diet and exercise.
Okay, so we're going to talk about nutrition for sure. Definitely. Non-stress test for her baby as she enters the second or third trimester. Yes. What about teaching? Teaching. Yeah, you're supporting your client. And then another thing you probably didn't think of was referring. She needs to go see her nephrologist. She needs to go see the ophthalmologist. She needs to go see the nephrologist. So she needs this in a cardiologist. She needs to be worked up from all the other specialties so that they know she's pregnant and it could have effects. We need to do EKGs so we have a baseline on their heart health. So this defines the two kinds of diabetes. So this is a really important slide. So the needs for insulin vary during pregnancy. So at the very beginning of the pregnancy, between weeks 7 and 15, the need for insulin is less. Okay. Once our client reaches week 20, the age of viability, reaches week 20, things change. At week 20, we see blood pressures tend to go up, gestational diabetes or gestational hypertension. Sugar levels go up, gestational diabetes, if they don't have regular diabetes. The need for insulin climbs all through that second half of the pregnancy. So if we have a type 2 diabetic, we're going to need to increase their medications probably. Okay. So increased insulin resistance is also known as a diabetogenetic phase. Okay. And the purpose of that is just to ensure that the fetus receives ample glucose. If we have a client who is a type 2 diabetic and they come to see us and they're pregnant, we're worried at that point, what is their sugar? What has been their sugar levels averaged? In other words, an A1C isn't that accurate during pregnancy. We don't usually use it. We might collect it at the very beginning if they're only like 8 weeks pregnant, and we'll have an idea of what their levels were over the past 3 months. But if you're much beyond that, it's not going to tell us a whole lot. But the poor control of blood glucose prior to pregnancy or during the first 8 weeks of pregnancy causes congenital defects. Okay, so you have a client who's 8 weeks pregnant and she comes in for her first prenatal visit. If her A1C is 8, she probably has a baby already with defects. That's too high. I had a client that came in, she was 32 years old. She was a type 2 diabetic, did not take good care of herself, and she was pregnant. Her A1C was 12.5. That's high. Well, she did have a very difficult pregnancy. She went into heart failure after delivery. Her baby had defects. It was a very sad story, very sad story. And it can be prevented. So this is about preconceptual counseling. Women need to know if they're a diabetic. They've got to get that sugar down before they get pregnant. So a lot of type 2 diabetics usually don't carry a pregnancy. They usually miscarry, have a spontaneous abortion because their sugar levels are high. Our diabetics are at risk to develop high blood pressure if they don't already have it. But one thing that was on the exam that we realized that you hadn't been taught yet was about polyhydramnios. Everybody got credit for that question, but remember, if mother has glycosuria, she has sugar in her urine, she's hyperglycemic, she's peeing a lot, she's drinking a lot. Same with the fetus. The fetus is going to be thirsty. The fetus is going to be drinking a lot, but not peeing a lot. So there's excess amniotic fluid around the baby. So it's called polyhydramnios or just plain hydramnios. Okay, because the baby's peeing a lot, just like the mother is. Okay. Women that have diabetes, that have big babies, that have lots of fluid, are at risk for abruption of the placenta. They're at risk for just uterine dysfunction. Contractions might not be they might be erratic. The uterus might have trouble involuting postpartum. So they're at risk for postpartum hemorrhage. They're at risk for preeclampsia. And then the baby is at risk for a lot of problems. Okay. So it's not a good scenario to have hyperglycemia during pregnancy. So antepartum care is very crucial that we get that sugar at a target level. We need to assess these women early and frequent assessments. So she's going to be at risk for a baby with neural tube defects. So if we have a client who's a diabetic and has come to us for some preconceptual counseling, we need to get her on some extra folic acid, which is true with a lot of chronic illnesses. We put them on extra folic acid. And we definitely need to double check the alpha fetal protein. Frequent ultrasounds, because we're watching for growth and development of the fetus. So usually week 28, week 30, we begin to do fetal ultrasounds every 2 weeks, if not more often. So that's what we refer to as fetal surveillance, doing the ultrasounds. And then we also might do the non-stress test that Annie brought up, because the non-stress test is going to tell us how well the placenta is functioning. Is the baby receiving adequate oxygenation when the baby moves? Okay, so it does tell us a lot. Okay, this is just, of course, they're also at risk for intrauterine fetal demise. That means dying before birth. Extreme prematurity and placental insufficiency. And then postpartum are diabetics. The babies, you're going to see respiratory distress and hypoglycemia. Remember, during the pregnancy, mother was hyper, so was baby. And so baby is used to a lot of sugar. Once that cord is clamped, no more sugar, hypoglycemic. So that's why it's really important to have our diabetic mothers or our gestational diabetic mothers as well to get that baby fed within an hour or two after delivery. Breastfeeding, most ideal. Okay. So we do a lot of teaching with our diabetic clients. We want to see them often. We want to see their glucose logs. We want to see what their sugar is in the morning, what they ate for breakfast, what it was 2 hours later, what it was before lunch. We're looking at what's going on so we can make adjustments and do some encouragement. So here are the signs of hypo and hyperglycemia. Okay, you think of hypo as being wet. Okay, nervous, diaphoretic, weak, blurred vision, pallor, clammy skin, shallow respirations, numbness and tingling, paresthesis, that's what that means. And then hyperglycemic as being flushed, thirsty, nausea and vomiting, deep respirations. They're called Cosmal respirations because she's trying to blow off acid, trying to blow off carbon dioxide to try to balance her pH in her blood. Okay. Deep, rapid breathing. So you need to know those signs and symptoms, no matter what field you're working in. So what should your client eat? So you need to be willing to teach your client what signs and symptoms of hypo and hyper are. What can she do if she's having symptoms of hypoglycemia? What could she eat? A little orange juice, a regular Coke or a regular Pepsi, hard candy, milk. If she could do milk and orange juice or milk and hard candy, it would be good because milk's got the extra protein and that will help too. All right. So these are the target ranges, and you need to know these. The target ranges for pregnancy. So since a mother can go into diabetic ketoacidosis much easier when she's pregnant, then we have to be more strict with glucose levels. So the best way to monitor glucose levels in a diabetic is blood glucose. We don't do A1C, okay? Blood glucose, so mother's gonna do her own at home. So we want her finger stick to be between 60 and 95 in the morning before she eats. It seems low. And it's gonna be tough for a type 1 or type 2 diabetic to get down that low, but it's a goal. And then before lunch, 1 hour after any meal, we want it below 140. And then 2 hours after a meal, below 120. And then middle of the night, we don't want her levels to go too low in the middle of the night. So it needs to be greater than 60, between 2 and 6 in the morning. So that's why we always do a night snack for our diabetics. Okay. I don't know if that's on page 247 anymore or not. That's the old book. So these are just some of the fetal surveillance things that we do. with the diabetic client. And then the postpartum risk. If our baby gets too big, C-section. Okay, so if you have a diabetic who is already at risk for infections, and then she's pregnant, that increases the risk. And then on top of that, a C-section, she's at risk for infections and blood clots, more so than any other client. So we always promote breastfeeding for our diabetic mothers because it delays the development of diabetes in the baby later on in life. Okay, so it does reduce the risk factors. We want to make sure mother eats before she actually breastfeeds. We don't want her to be hypoglycemic. Her milk production will drop down. Some of you still aren't on video, and you're supposed to be on video during class. Even if it's not working well, I still need to see you. Rocky, you too. So we test for gestational diabetes. Who knows the difference between type 2 diabetes, type 1 or type 2 diabetes, and gestational? What's the difference?
Gestational you get while you're pregnant, and your sugar usually goes back to normal afterwards, after
Okay.
you deliver, and your hormones get back to normal and whatnot.
Right, exactly, Clarissa. So a type 2 diabetic is not gestational. So we don't need to do any testing, glucose tolerance test on a regular diabetic. We already know they're diabetic, okay? But every woman can develop gestational diabetes in her pregnancy. So it's standard of care to test them for that about week 28, okay? So we use the glucose tolerance test. You don't have to memorize this test. Okay. And then you do need to become familiar with your insulins. Okay, rapid acting, short acting. How important is it if you have a diabetic on the floor in a med-surg unit that is on insulin, you're giving insulin, you're checking the glucose level before they eat? How important is it that they have food in the room if you're given a rapid acting insulin? It's very important. Don't give insulin if there's no food around, okay? Because a lot of them will have a quick onset. Okay. So, once again, which clients are at risk for hyperglycemia? What'd you come up with? Group 1.
People that have a family history of it, obesity, high blood pressure, and cholesterol. Your race, being Hispanic, Latino, sedentary lifestyle, your age.
Okay, all of that come into play when you're pregnant, okay? So you are more prone to have hyperglycemia. And of course, if you're diabetic, you're going to be more prone to have a higher level of glucose. Okay, good. So the preconception concerns would be, we need to get that sugar below, lower than, 7 or 8 before you even get pregnant, and being very strict during pregnancy with glucose levels. Okay. Antepartum concerns then would be congenital defects, right? If their sugar levels are high at the beginning of the pregnancy, But once they get to labor and delivery or late pregnancy, we're more concerned about injury, having to have a C-section, a large baby, that sort of thing. Injuries to the fetus and the mother during labor. Okay. And then postpartum, what'd y'all come up with? Hyperglycemia in the postpartum period. This kind of goes along with intrapartum. Did you come up with anything? No. Okay. So postpartum is difficulties are associated with the labor and delivery. So birth injuries, having to have a C-section, that sort of thing. Okay. So diabetes, hyperglycemia, early pregnancy, congenital defects, late pregnancy, polyhydramnios, too much amniotic fluid, too big of a baby, C-section, infections, blood clots. So during her pregnancy, monitoring her glucose, teaching her frequent assessments, fetal surveillance, non-stress tests, growth ultrasound, BPPs, things like that for our diabetic clients. Okay. So that was a lot to take in. I didn't really expect you to be prepared for that. Okay, so let's talk about any questions about diabetes. So probably the most important thing you need to know about diabetes are on the slides I've given you. Okay. You don't have to know about the glucose tolerance test. It's just a matter of a client coming into the lab starving, and we give them a sugary drink, and then 1 hour later we draw their blood glucose.
Can you go
Okay.
to slide 11 for a second? I just need to,
Sure. Slide 11. Okay, yes. Oops. I believe this is in your text too, but this is a nice chart. You can do a screenshot if that would help.
I got it. Thank you.
You're welcome. Does anybody want a quick break before we go on? Yes? Okay.
Yes, please.
Okay, let's say at 20 after. Okay, I have 4:11. We'll say 20 after. And somebody remind me to resume recording. Thank you. Your textbook talks about, high risk pre-existing diseases. And it's very thorough, it's very detailed. So what I have done for you is to put it all together on a chart. Okay, so this is a chart about hypothyroidism. What, as nurses, what does that mean if they're going to get pregnant? Well, we have to make sure their thyroid levels are at least within a normal range. Low thyroid can lead to problem with neurodevelopment in a fetus. So that's probably the only thing you need to know about hypothyroidism. Hyperthyroidism is they're at risk for preeclampsia. So any disease like hypothyroidism, hyperthyroidism, anemia, heart disease means that the placenta might not be as healthy. Okay, an unhealthy placenta has a full cascade of problems. Okay, so that's why preeclampsia is going to be a risk factor if a client is hyper, anemic, diabetic. Okay, so preeclampsia is one of those, and we'll talk about that today. Okay, anemia. There's all kinds of anemia. Okay, there's blood loss anemia. There's iron deficiency anemia. And what kind of behavior do we see in a client with iron deficiency anemia? Do you remember?
Pica,
Pica, yeah, they're going to eat non-edible items or things that aren't meant to eat, okay, like ice chips, dirt, chalk, okay. So iron deficiency anemia, what we need to do as nurses is to make sure our clients understand how to take their iron, their oral iron, empty stomach or orange juice, okay. If they're also on thyroid medication, we don't need to give those two medications at the same time. So thyroid, they take in the morning on an empty stomach, and then they can do their iron at night or during the day and at night on an empty stomach or some orange juice. Okay. Let's see, what else is good to know on here? Autoimmune diseases like myasthenia gravis and lupus. So those two chronic illnesses, autoimmune, they're two illnesses that have unhealthy immune systems. Okay, so their immune system tends to destroy something in the body. So myasthenia gravis, the communication between the nerve and the muscle, that synapse has inadequate amount of acetylcholine. So myasthenia gravis, you're going to see respiratory problems. Okay, so if we give our client an epidural, it might aggravate that. Myasthenia gravis, also our newborn might have transient myasthenia gravis. In other words, transient difficulty with breathing. Okay, and it's usually 6 weeks out. I don't even know how long it lasts, but myasthenia gravis. So I highlighted those things in this chart. Lupus is connective tissue, vascular tissue disease. So it depends where its primary effect is. It could be in the lungs, it could be in the gut. Okay, but clients with lupus are more prone to blood clots. Okay, we put them on extra folic acid. We put them on a low dose baby aspirin. These women are going to increase risk for preeclampsia and preterm birth, growth restriction. Okay, usually during the pregnancy, these two particular illnesses are quiet. In other words, they feel pretty good during their pregnancy. But once the pregnancy is completed, that's when lupus will flare up or myasthenia gravis symptoms will flare. Okay, so that's what's important. So I just highlighted all the things that are important for you to know. Epilepsy, any kind of seizure disorder, we need to make sure they're on the right medications and that they are taking their medications. We need them to keep a journal if they have a seizure. You know, if a client has a seizure, that means they're not breathing for that minute or so their seizure occurs. So that's kind of hard on a baby. Okay. During pregnancy, the threshold for having a seizure is lower. In other words, they're more prone to seizures during pregnancy. I've had epileptics that were pregnant and they didn't want to take their medication because they were fearful that it would harm the fetus. And I had to explain to them that there are safe medications we can give you. We can just switch it because you're more prone to have a seizure. So trying to get them compliant with their medication is a challenge. Substance use disorder. Substance use includes any substance that a mother has been using that she's become dependent upon. In other words, she's used to taking it. If she stopped taking it, she's going to have side effects, withdrawals. So that happens with antidepressants. Prescribed a woman that's used to taking antidepressants, withdrawing from them is hard. And so it's going to be hard for the newborn. And of course, opioids, heroin, any of the illicit drugs, hard on a newborn. So substance use is something we try in OB when we find out, when a client tells us they've been using something, we try really hard to get them to go into an outpatient rehab facility. Now, I know just every state in this country has particular outpatient rehab facilities for pregnant women in particular, because they can take Subutex is the drug of choice nowadays. Okay, Subutex, methadone. They are a safer, Subutex more safe than methadone during pregnancy because they have little effect on the fetus. And when that baby is born, there's not that much Subutex or methadone in the milk, but there's a little, so it helps with the withdrawal symptoms. So if mother is compliant with a rehab facility taking Subutex, we want her to breastfeed, okay? Because it's better for the baby and better for mother. But if she's not, if she's on opioids, we don't want her to breastfeed. If she's taking the other kinds of opioids, Subutex is a partial agonist, you might say, okay? The effects of narcotics she receives as far as feeling better, but the euphoria isn't there, like Nubain or Stadol, butorphanol. And those are also partial agonists, if you remember. So our substance abuse clients, we have to make sure we also screen for depression, because the research has shown us that substance abuse and depression go hand in hand. Okay, so make sure you're monitoring for that as well. Cardiovascular disease and pregnancy. We talked about the demands of the heart during pregnancy, during labor and delivery, during postpartum, the shifting of fluid, the demand for oxygenation. So it's hard on a heart. If she has heart disease, we have to know what the signs of heart failure are. Okay, the signs of difficulty with the heart. Who can tell me the signs of heart failure? When the muscle of the heart is not able to keep caught up with the demands of oxygen, when the blood tends to back up. What are some symptoms and signs?
Edema.
Tension, shortness of breath.
Edema, peripheral edema, and jugular venous distension. So right-sided heart failure, you're going to see the jugular venous distension and the peripheral edema. Left-sided heart failure is the shortness of breath, because that's the lungs. So the blood is backing up to the lungs, which causes fluid accumulation. So you have to look for those signs. What if she's going into shock, cardiogenic shock? Other than what you've already mentioned, what else?
Low blood pressure.
Okay, blood pressure drops, heart rate goes up, tachycardia, right? Diaphoresis, sweating, nauseous, okay? Cool clammy. All right. Any pulmonary problem, especially primary pulmonary hypertension. These women cannot tolerate pregnancy, period. Okay. So going back to cardiovascular, heart disease, high blood pressure. We're not going to give medications that are going to cause tachycardia. We're not going to give medications that are going to increase the heart rate or the blood pressure. So there's some contraindications for some of the meds we give in OB. Terbutaline, Methergin, methylorgonavine, those two medications we don't give to any client with a cardiac condition. Some women develop a cardiomyopathy after they deliver. They had no heart disease or any problems until after they deliver. And this is a really sad condition because there's not much we can do other than support the heart. It takes a long time to get over it. And I don't think the mortality rate is that high, or that, I mean, the mortality rate is higher from dying within 5 years after going through myopathy after a baby. Okay, so that's the pre pregnancy chronic diseases list. All right. Any questions about that? Let's talk about who knows what preeclampsia is? Did anybody do any reading about preeclampsia? Does anybody know what it is? Anything at all?
It's when your blood pressure is high and gets to the point to where you can have a seizure.
Okay. Blood pressure climbs and something's occurring that causes the blood pressure to go up in pregnancy. And so this is one of those gestational issues. In other words, it's occurring only during pregnancy. And these gestational issues are occurring after week 20. Okay, so we have gestational hypertension, we have preeclampsia, we have gestational diabetes. Okay, so preeclampsia is one of those things that can occur. So remember, I talked about an unhealthy placenta, right? When you think preeclampsia, think placenta. I think day one of the class, I said how important it is to understand that pregnancy is all about the placenta, right? Blood flow to the placenta. Okay, so preeclampsia. All right. Let's just go over a PowerPoint slide. Let me check my chat here. Rocky, are you still here? There she is, Rocky. Rocky, do you hear me? I don't think she hears me.
Yeah, I can hear you.
Okay. Are you still meeting with me after class today?
Yes.
Okay. Well, Samantha, that means I can't meet after class. Okay. So we have another time scheduled. Is that still okay?
Yeah, I made a time with you tomorrow at 4:30.
Yeah. Okay, good. I just want to make sure we have that clear. Okay. So chronic hypertension. Well, first, to start at the beginning. So these are things that can happen during pregnancy. And these are fascinating. I love diabetes, but these are also fascinating. So things that can occur. So hyperemesis gravidarum. So when you think of hyperemesis, what do you think that means?
It's
What's
excessive vomiting.
Okay, so a lot of vomiting, right? Hypervomiting, right? Hypervomiting. Gravidarum just means during pregnancy. Okay, hyperemesis. How do we know the difference between regular nausea and vomiting and hyperemesis gravidarum? There's a difference between the two.
It causes weight loss and the ability to absorb nutrition.
Hyperemesis also lasts the whole pregnancy.
Hyperemesis.
And it doesn't stop. It typically doesn't get better. It's whereas with nausea, vomiting, like regular morning sickness, that tends to alleviate at some point, whereas hyperemesis does not.
Okay. How do we define it medically?
They lose, I believe it's 20% of their body weight.
Okay. They're dehydrated. Okay. So let's say you have a client come into the emergency room and she's pregnant. Let's say she's 10 weeks approximately, and she says she has been vomiting for days on end. She can't keep anything down. Ice chips won't even go down. And she's obviously dehydrated. What would be your priority?
Replacing
She's
the-
laying there, she's throwing up, and she doesn't have anything to throw up. What's your priority? Go ahead, Corey. You started to say something, didn't you?
Yeah, replacing
her fluids.
Okay, we need to start an IV, don't we? Yeah, that's your priority. She's dehydrated. What else could be happening? She's throwing up. Everything's gone.
Metabolic acidosis from the lack of electrolytes.
Okay, so she could be acidotic. She could be, she's throwing up all her bile from her stomach, so a lot of acid. Okay, so she could have hypokalemia, right? Metabolic disturbance. That's how we defined hyperemesis. It's not weight loss. No, we define it medically as an electrolyte imbalance. So we need to, let me type this in. So electrolyte imbalance, okay? That's how we define it. So we've got our IV running because we know she's dehydrated. What would you do next? What would you do next?
Nausea meds.
Okay, we could give her some antiemetics. Good. We could give her Phenergan, Zofran, Reglan, Compazine. What else? We're giving her that. What else do we need to do?
Monitor the baby.
Okay, maybe we need to do a Doppler or an ultrasound to verify she's pregnant. Maybe she has a molar pregnancy. It's not uncommon, a molar pregnancy, to have a lot of nausea and vomiting. What else do we need to do? What's critical to know?
For lab values.
Yeah, we need to draw some labs. We need to see what our electrolytes are. Okay, and replace them. Okay, so hyperemesis gravidarum is defined by an electrolyte imbalance and dehydration. Okay, yes, she probably has lost a lot of weight. So what's this? What's this a picture of?
Is it an ectopic?
Ectopic, that baby is in the fallopian tube. That's the ovary underneath the baby there. So the uterus is over here. What are some symptoms of an ectopic pregnancy?
Pain,
Okay, sharp pain. What else? What are your concerns?
Hemorrhage and bleeding.
Hemorrhage and bleeding, yeah. So this is bleeding. They can lose a client with an ectopic can really lose a lot of blood internally. And she might have some vaginal bleeding as well, because that blood can back up into the uterus. Okay, so this is, it depends how far along she is, how it's managed. If it's early, we can use methotrexate, which is a folic acid inhibitor. So it causes, it stops growth of the pregnancy. If it's too late, we have to do surgical removal. Spontaneous abortions. So the difference between threatened and inevitable are three factors. Number one, amount of blood flow. If it's just threatened, she's just bleeding a little bit. Inevitable, she's bleeding a lot and even might be losing some fetal tissue. Cervix, threatened abortion, the cervix is still closed. Inevitable, it's open. And so the third thing is pain. If it's a threatened abortion, she's really not in any pain. But there's pain with inevitable. She's having some serious cramping. Okay. So usually just about any type of abortion, it requires a surgical intervention to remove the tissue. Now, with a threatened abortion, we can probably save it as long as that cervix is still closed. So just some bed rest, okay? But the other options require us to do what's called a D&C and go in there and remove the tissue. Okay. AZ, you're off. A lot of you, I don't see you in your video. And that's just, we can't do that. You need to show me your face. You need to be, it's just like a regular classroom. You need to be present. Okay. Lauren, I can't see you either. Okay, molar pregnancies. Molar pregnancy is a fertilization with missing maternal DNA. So it's not a true pregnancy. What happens is that those trophoblastic cells along the uterine lining begin to grow like crazy. So they're almost like little cysts growing. And with molar pregnancies, nausea and vomiting, the abdomen, the uterus is going to look like she's farther along in her pregnancy than what she is, because it's only a molar pregnancy. HCG levels are going to be higher. So molar pregnancies are precancerous because of the exponential growth of the trophoblastic cells can lead to cancer. So we have to remove the trophoblastic tissue completely. And we're also doing serial HCG levels, because trophoblastic cells produce HCG. Okay, so as soon as those get down to 0, we know that we've got all the tissue out. So that's a molar pregnancy. Hypertension, define hypertension. Well, in pregnancy, we define it as greater than 140 or greater than 90 or both. Okay. So we're going to measure, we're not going to measure her one time and say you've got high blood pressure. We're going to measure again later. Okay, either later in the week, at least 4 to 6 hours after our initial measurement. So that's high blood pressure. Chronic high blood pressure is she had high blood pressures before she got pregnant. It's a problem she has. It's a pre-existing disease. Okay. So if you have a client that comes in and she's only 12 weeks pregnant and her blood pressure is high, she has a chronic problem. We don't diagnose a woman with gestational hypertension until after the 20th week. So if her pressure has been fine for the first 19 weeks of her pregnancy, and then week 24 or something, it goes up, that's called gestational hypertension. Okay. Chronic hypertension can cause small babies, placental abruption, right? She could develop preeclampsia and we not know it. Okay. Increased loss of the fetus and preterm birth. Okay, so that's your chronic high blood pressure. If she comes to the office and she's early pregnancy and her blood pressure is already up, she has a chronic problem. The pregnancy is not causing her blood pressure to go up. There should be no change in blood pressure during pregnancy, theoretically. So this is a comparison I came up with to help you remember that chronic is present during the first trimester and all the way through the pregnancy, whereas gestational is not present until the 20th week. And then it's done at the end of the pregnancy, it goes away. Okay, just like gestational diabetes. It's present when the woman gets pregnant, it continues through the pregnancy and on. Whereas gestational diabetes is not diagnosed before 20 weeks. But at the end of the pregnancy, it resolves itself. Preeclampsia. Okay. High blood pressure doesn't cause preeclampsia. Okay. Preeclampsia causes the high blood pressure. If you think of the unhealthy placenta, the blood vessels in the placenta are not relaxed enough. Okay, they're not relaxed enough. And the blood flow, and there's a trigger that goes on. And all the blood vessels in the kidneys, the heart, and the lung, and the brain all have a spasm. The trigger is system-wide. So it starts in the placenta and then it spreads. It's called preeclampsia. Okay, so a history, if mother has had it before, she could have it again. Family history. If a mother is carrying more than one baby, or African-American women are more prone to preeclampsia. Obesity, nicotine, poor nutrition, all those things that cause an unhealthy placenta. Younger women and older women. It's really not, it's hard, it really is hard to predict, okay? So you can look at that. I'm not gonna, whoops, sorry, went the wrong direction. So the pathophysiology of it is one of the vessels, or not one, the vessels in the to the placenta actually constrict. So if you look at this picture down here at the bottom, the one in the middle is the preeclampsia. What we want to see in our placenta is this wide flow, low pressure blood, because that's going to provide the best blood flow for the fetal vessels. Okay, but during preeclampsia, it's reduced. So here's preeclampsia then, because it's system-wide, it affects the brain, the heart, the lungs, and the kidneys. So we're going to see signs in each of those organs, each of the systems that indicate preeclampsia. And these are the signs we're monitoring if we suspect our client has preeclampsia. So we've got protein in the urine, okay, creatinine levels rising. That's because the kidney is being injured. Central nervous system, because the brain is affected. Cerebral vessels are constricting. Headache, visual changes, hyperactivity of reflexes. Deep tendon reflexes are hyperreflexive. The lungs, pulmonary edema, shortness of breath, and then the liver. The liver, you're going to see lower platelet levels, okay, elevated enzymes, okay. You're going to see, so basically that's what that slide is telling us. And we're going to go over this more than one time. Worsening preeclampsia is severe preeclampsia. And the only difference between regular preeclampsia and eclampsia and severe is higher blood pressure and the liver. It's all about the liver. Okay, so liver is being injured by preeclampsia. So we call it severe. So hemolysis occurs, which is the breakdown of red blood cells. Liver enzymes really climb and the platelets drop. So she's going to be bleeding. Petechiae. Anybody with liver disease, you're going to notice petechiae. Okay, you're going to see petechiae. Those are the tiny little blood vessels that have a pinpoint red spot with liver disease. So your assessment are going to be central nervous system assessment because the central nervous system is affected. So you're going to assess, you're going to ask your client about headaches. In fact, one of the first symptoms that a client will say to you, I have a headache. I've been taking Tylenol, nothing's working. And in your mind, you should automatically think preeclampsia. Okay, do you remember the question on the exam about heartburn accompanied by headaches? That's preeclampsia. That's a sign of preeclampsia or HELP syndrome. Okay, so cardio or central nervous system would be level of consciousness, your deep tendon reflexes, headaches, vision changes, speech. Cardiovascular system, increased heart rate, of course, high blood pressure, pulmonary edema, peripheral edema, and then the kidneys. Urine output is reduced because the kidneys aren't functioning as well. And the creatinine, the serum creatinine levels are going to go up, which is a sign of renal insult, you might say. So this slide is just a reminder what we mean by deep tendon reflexes. That was a long time ago in health assessment that you learned about deep tendon reflexes. So I thought I would remind you. So normal reflexes is a 2+. So with preeclampsia, it's going to be a 3+ or greater. Clonus being the worst. So clonus. So here's our treatment for preeclampsia. So we know during preeclampsia that the levels of calcium in the brain are elevated and the magnesium levels are low. We need to rebalance it to reduce the brain effects. Okay, so if we give magnesium, then we're reducing the risk for seizure activity. Okay, we're protecting the mother and we're protecting the baby. Okay, so we usually give a loading dose of magnesium sulfate and then a maintenance level. Okay, So because of what magnesium sulfate does, we have to monitor those systems, right? Monitor the central nervous system. Magnesium is a central nervous system depressant. Monitor respiratory rate, heart rate, urine output. So if you have a 32-year-old diabetic that's admitted with preeclampsia, what would you expect her vital signs to be?
High blood pressure from the
Okay.
course.
So she's going to have high blood pressure. What else might she be experiencing? If she has preeclampsia and the doctor or the provider decided she needed to be treated with magnesium, what other things could she be experiencing? What else might you expect to see?
Protein in the
Protein in her urine.
Protein in her urine. It's a lot to think about.
blurred vision.
Okay, so she might have blurred vision, a headache.
Mhm.
Definitely.
Edema.
Okay. So it's diagnosed by high blood pressure plus at least one of those other signs. Okay. She doesn't have to have all of those signs or symptoms. She only needs high blood pressure and one. Okay. Because she might come to the hospital with a headache and high blood pressure and nothing else yet. That would be nice. And we could go ahead and treat her with magnesium and prevent all the other problems. So magnesium is a depressant, a central nervous system depressant. So if we give her too much and she becomes toxic, then you're going to see the opposite, right? She's going to be lethargic. She might have slurred speech, bradycardic, respiratory rate plummets because it's a central nervous system. Deep tendon reflexes, she might not have any. And then toxicity of the urine with high magnesium levels, so she might not have any urine output. Okay, so it's the opposite. So there's a balance we have to do with our magnesium. And then lastly, or not lastly, but another something else that can occur during pregnancy besides preeclampsia and gestational hypertension is the placenta actually prematurely pulling away from the endometrium. Placental abruption. Okay. And it depends how severe it is. But if it's happening during labor, it is severe and it's life-threatening. Because once that placenta pulls away, there's no more blood flow to the fetus. And then mother can bleed out. And usually what we see is sudden and it's very painful bleeding, massive bleeding. Some of the things that can cause it are, of course, high blood pressure, but cocaine use. Cocaine is a very strict vasoconstrictant. Trauma. And so here's pictures. Here's a partial, and this is a complete separation. And then DIC. And the reason I put DIC in here, it is one of our concepts because abruption is what in pregnancy is what usually causes disseminated intravascular coagulation, DIC. Okay. So DIC is, does anybody know what DIC is? It's not particular to OB, it's anywhere, any group, any client. If you have a client that's older and septic, they could develop DIC.
Isn't it like bleeding out and clotting at the same time?
Okay, so the clotting occurs first. So consumptive coagulopathy is sometimes what it's called. In other words, something triggers, we don't know, the onset of massive clotting throughout the body. If you look it up on Google and look at pictures, you'll see clients with purple fingers because the blood flow clotted off and began to die because there was no blood flow. Okay, and then because all the blood clotting factors were used up, now the massive bleeding. So we treat with fluids and replacing those clotting factors. So that's what DIC. So what are you going to see clinically if you suspect DIC? If your patient's bleeding, what do you think you're going to see clinically? I think this might have been on your quiz. If you don't have any clotting factors, you've used them up and you're bleeding everywhere, what might you see clinically?
Low blood pressure, high heart rate, pale color, and decreased urine output.
Okay, you also might see hematuria, blood in the urine, right? Blood in the urine. What else? You might see bleeding gums. Or an IV site, you might see bleeding IV site because the vein is bleeding. The tissues are bleeding. There's no clotting going on. Okay, massive vaginal bleeding for an OB client. So hemostasis, homeostasis is the balanced clotting and breakdown of the body. Okay, so hemostatic means to stop the blood flow. Homeostatic. Fibrinolytic system. Okay, that means the breakdown of those clots, because it clots and then it's broken down. It's clots and it's broken down. It's a nice balance that our body is doing all the time. Okay. All right. Placenta previa is something else that can occur during pregnancy. It's basically the placenta is too low in the uterus and mom is bleeding. Okay. And with placenta previa, there's no pain. Okay. It's that some of the placenta is not attached to the wall of the uterus, so there's bleeding going on. Now, it doesn't mean immediate delivery. It depends how much mother's bleeding. It depends how the baby's doing. But eventually she'll need a cesarean section because we can't deliver vaginally. There's no way to control blood loss. Okay, so that's a placenta previa. And then cerclage is another thing. So cerclage is basically, or a cervix that can't remain closed. It's incompetent. It can't contain the fetus. It's insufficient. So you'll see all those terms. So usually what we do, and we usually diagnose this early in pregnancy. When we do an ultrasound, we can see it early in pregnancy that her cervix is opened. So we can do what's called a cerclage, and that just closes up the cervix. There's different ways of doing it. In this picture, they just put a band around the cervix, and they could do that vaginally. And we give supplemental progesterone. to support that pregnancy. So if we do an intra-abdominal, in other words, surgically, we're going to go into the pelvic cavity and we're going to go above the cervix. Okay, we're going to be at the very low part of the uterus and put a band that way instead of going through the vagina. So we're doing an intra-abdominal surgically. So it means that when it comes close to 36, 37 weeks, we have to go in and do a C-section. Okay, and then remove the band. Okay, so let's say that we have a client go into the hospital at 10 weeks, and we're going to do a cerclage. Okay, we need to teach her what postpartum. What do you think the answer is here? You can put it in the chat if you want to. Anybody have any idea? Select all that apply. Okay. Should she report vaginal discharge of any kind to the provider?
Yes.
Actually, no, because discharge is normal in pregnancy. So we don't need to know about that.
Would that not fall under like bloody discharge? I was just thinking all general vaginal discharge.
Okay. So bleeding, yes. Bloody discharge, yes. Okay. But not just plain discharge. That's a good clarification. Yeah. Okay. So blood, yeah. Bleeding, definitely. What about the presence of any cramping or low back pain that might indicate preterm labor?
Yes.
Yeah, she needs to let us know. She also needs to let us know, we need to let her know that she might need to make arrangements because she might be restricted in her activity level, especially if we do an abdominal, intra-abdominal placement. Okay.
I didn't
And then-
realize they then still did abdominal cerclages. I've placed many cerclages and I've never done an abdominal one.
Okay. It's more risky, that's for sure. And I'm sure it depends on the situation, Kelly. But yeah, they still do them. But probably not as many as they do the vaginal placements. Okay. All right. So the C, making arrangements, would only be if she had an abdominal. Okay. Only if she had an intra-abdominal placement. But usually they go home and they're fine. Okay. All right. All right. So that was a lot of information on, on the things that can occur during pregnancy. And so you just need to go back, take those slides and go to your book and look at pictures, read the graphs and stuff. So let's look at this one. We're going to talk about our client here. And this case study, we did a case study on Anna. She ended up being high risk because she developed gestational diabetes and then preeclampsia. So when we think about what makes a pregnancy high risk, remember, pre-existing diseases make it high risk, or the things that occur during the pregnancy. So we talked about placenta previa, abruption, we talked about molar pregnancy, hyperemesis gravidarum, we talked about previa. So all those things, or just high blood pressure, okay? So those things we can say, you're automatically high risk now. We need to survey your baby more often. We need to have you come into the office more often. We might even send you to a high risk specialist to co-manage your care. So when you look at this picture, risk factors for poor pregnancy outcomes. She's young, right? And she might be underweight. Okay. So with a client like this, she's high risk, even though otherwise she has no chronic diseases, but she's young, she's a teenager. Okay. So when you're, thinking about answering questions on an exam, think about the big picture. She's young, and even though she doesn't have any chronic risk factors, it's her age and maybe her weight that make her high risk. Okay. So we need to monitor carefully. Then we have a client that comes to the clinic. She's 43 years old. She's a G5, T2, 1, 0, and 2. Gestational age of 22 weeks. 3 previous cesarean deliveries. Premature twins was 1 and a demise. BMI is 28.9. Blood pressure 142/88. Do you see her as high risk? What are some high risk factors about her?
Her age.
Her age,
Her blood pressure,
her blood pressure is a little up there, isn't it? Yep.
her BMI.
Okay. She's overweight, but she's not obese. Okay. What else?
She's had twins with 1 demise.
Okay. And those twins were probably preterm. She approaches the clinic at 22 weeks. So she's late to prenatal care. She didn't get all the benefits of early pregnancy. Okay, so that's another huge risk factor. We always promote early pregnancy. Now here's a 24-year-old client. She's at 32 weeks. She's gained 25 pounds. So usually 1 to 4 pounds the first trimester, and then a pound per week after that. So that's not too bad. And she's at 140/86. Is this gestational hypertension she's developed, or is it preeclampsia? What would you need to see to diagnose her with preeclampsia? So which is it?
Would you have to see her if she has the protein in her urine before you can actually
Okay.
say if it's preeclampsia?
Okay, so we need to see another sign or a symptom, don't we, besides high blood pressure? So it could be protein in the urine. That could be the only thing. And then we would say, yep, we need to do some blood work. Okay, what else could we see? Anybody remember? She might have a headache, right? She might have come to the clinic with a headache. So if you have a client that calls the office and she's like in her 30-week pregnant, and she says, I have a headache, I've been taking Tylenol, I can't get rid of it. And so you have her come to the office, what's the first thing you want to do? So she's at home, she's 32 weeks pregnant, and she calls the office and says, I have a headache, I can't get rid of it with Tylenol. You say, well, come on into the office. Let's check you out. What would be the first thing that you would want to do?
Is it to get the fetal heart rate?
Even before that,
Before that.
Take her blood pressure.
Take her blood pressure, yeah. Yeah, because if her blood pressure's up, then we know right away what's going on. Okay, so take her blood pressure first. And then you can dip her urine, and then we can draw blood for liver enzymes and stuff. Which I just told you. What lab orders would you want to do? When you think about preeclampsia, what labs do we want? Okay, so for the liver, it's going to be the liver enzymes, the liver function test. So we need to draw a liver function test. What else do we know?
Creatinine level.
Okay, creatinine level, renal function, even a 24-hour urine for creatinine and protein. What else? One more. Okay, we need to get a CBC to look at our platelets. Okay, so the liver, elevated liver enzymes, and decreased platelet level. So if our platelets are low, it's just further verification of preeclampsia. Okay, so what's the prescription to treat preeclampsia? What drug do we use to treat it? It's a central nervous system depressant, and it's not alcohol.
What was the
Magnesium.
question again?
Magnesium. Yeah, magnesium sulfate. Yes. And then if we have to, if her blood pressure is really high, we're going to have to give her antihypertensive. And we can do labetalol, hydroxyline, okay, such as that. We can also do nifedipine for blood pressure. So it's magnesium sulfate. Mechanism of action is a central nervous system depressant. Adverse effects, well, toxicity. The patient's going to feel warm, tingling. They don't like the way it feels. So we're going to do a bolus, usually 4 to 6 grams within 30 minutes, and start a maintenance dose. And then add some antihypertensives. So because we're using a central nervous system depressant, we have to monitor the side effects, right? If you give a medication, you have to monitor the effects. So this is a continuous. So what clinical parameters do we need to monitor then if we're giving a central nervous system depressant?
Respiration and blood pressure.
Okay, so it affects the central nervous system, which regulates heart rate, blood pressure, respiration. So we need to make sure we're assessing those, the vital signs. What else?
Deep tendon responses, seizure activities.
Okay, so we need to assess her central nervous system. Okay, so assess her deep tendon reflexes. You can just do one. Check for clonus. Does anybody remember what clonus is?
It's when you push back on the foot and it twitches coming back.
That's right. So you've got the foot here and you're pushing dorsiflexing. If it bounces rhythmically like this, it's called positive clonus. And that's a sign of an impending seizure. Okay. So you need to assess the deep tendon reflexes. What else are we going to need to monitor?
Urine
The
out.
fetus.
Urine output. And what else did somebody say?
I said the fetus, but
And the fetus. Absolutely, the fetus. Because if it's depressing mother, it's also depressing the fetus. But that can be a good thing because we're improving fetal circulation, brain circulation. It protects those very fragile fetal vessels in the brain and the eyes. That's why we give magnesium sulfate for preterm labor, is for the baby. Okay. So toxicity. She's receiving magnesium. So what do you think you would see if her magnesium levels become too high?
Urine output less than 30 mLs.
Yeah, magnesium is toxic to the kidneys. So you might see shutdown, total shutdown. So we're gonna see low urine output, if any. What else? I mean, we have really depressed that central nervous system with too much magnesium.
This is when they'll start having the seizure activities. They'll have the dysarrhythmias.
Well, they don't have seizure activities when it gets too low. Okay.
Isn't like a
But yes, definitely dysrhythmias in the heart, bradycardia.
like a +4 DTR.
She's toxic. In other words, she has too much magnesium and her central nervous system is really depressed. She's lethargic. Her speech is slurred. Bradycardia. Low blood pressure. That's what we would see. Maybe absent deep tendon reflexes because she's toxic now. So we have not enough. You're going to see hyperactivity, seizure activity. Okay. But when she has too much, it's the opposite. Okay. So our plan of action, so if you walked into the room and your client, you're doing you're going in and checking on her every 20 minutes until she's stabilized, and you come in and she's very lethargic and her speech is slurred, what would you do?
Stop the infusion.
Yeah, stop the magnesium for sure. Stimulate her to wake her up, get her to take some deep breaths and call the provider. So you'd probably have an order to draw magnesium level. Okay. And if worst case scenario, we could give her calcium back to rebalance our system. Okay. So let's say, how do you know the magnesium infusion is working?
The symptoms will start going away and then her lab values will come back in the normal range.
Okay, so she's going to have good urine output. She's going to be alert. Her vital signs are going to be stable. She might even be diaphoresing, getting rid of some extra fluid. Okay. Her urine output is good. So labs are good. That's how you evaluate your intervention. I know this takes some thought, especially if you're not that familiar with the concept. Okay, but this is how we think together. Okay. So we'll work on that again with the case study. We're almost finished here. I want to show you this slide and then we'll finish up. This is just another presentation of preeclampsia and the picture of the vessels and then the systems that it affects and what you would see, okay, and what you would monitor, okay. So I think I sent this to you. Here's just another one for preeclampsia. just another concept map to work on, okay? So I know this is hard, but I think if we try to keep it as simple as possible, it'll help you. Any questions? Kelly says that ACOG now, and that's the physician arm of obstetrics, that transabdominal cerclage would be used if mother had failed vaginal cerclage in the past. In other words, with another previous pregnancy, if they put in a vaginal cerclage and it didn't work, and she has another pregnancy, then they would want to do an abdominal cerclage. So it really depends on the client's history. Okay, thank you, Kelly, for sharing that. Any questions?
Your email, you sent out an email saying that we need to contact you about the calculations. I have not received a grade on that.
I haven't graded them all yet.
Okay.
Yeah, I got ahead of myself, but I just want to let you know, when we work on the calculations, I want you to know how to do the calculations. I mean, you need to know how to do these. So if you don't get them all right, then you need to contact me. But I'll be working on those grades this evening, Kelly. Okay. Thank you.
If they're not due until next week and you just happen to look at ours and see that I got less than 100, can you email me before you grade it?
You already submitted it, right?
Yes, ma'am.
I can't, once you submit it, I can't change your grade. But great. Good question. Nice try. Oh, it's only 1% of your homework grade. Okay. Anybody else have anything else they need to understand that I haven't been clear on?
Will you also send the example of the teaching plan as well?
Yes. I've got it. It's almost finished. Yeah, that'll help, Kelly. That'll help. Okay. Anything else?